Hello, everybody. Good morning. This is Dr. Eric Bricker with A Healthcare Z. I am so excited to see all of you. This is my favorite time of the week, is to be able to interact with all of you. So we are live now on LinkedIn and YouTube. And today's topic is healthcare incentive alignment innovation. What is it? How is it different? Why is it better? Now, I will say right now, for some people on LinkedIn, if you're having trouble seeing, but you can hear me, in the past, you've had to refresh your screen. So try doing that if you can't see me. And also know that for both LinkedIn and YouTube viewers, that you can type in comments or questions in the comments section, and I can see them on my side. And so what I will do is pause periodically through the presentation to answer your questions. So please ask away in the comments as we're going through this. So now, very brief background about myself. I did this last week, but want to reintroduce myself for those of you who don't know me. So I'm Dr. Eric Bricker. I actually used to be a hospital finance consultant before going to medical school, because hospitals actually hire outside consulting firms to show them how to get paid. And so I did this in projects at the University of Kansas Medical Center, and the Cleveland Clinic, and a Yale Associated Hospital, and a hospital system in Colorado. Fantastic experience, but still wanted to be a doctor. And this was in the 90s. And so I learned all about the coding and managed care and Medicare and Medicaid. It was a fantastic experience. Still wanted to be a doctor. Went on to the University of Illinois for medical school, which is in Chicago. Then did my residency in internal medicine at Johns Hopkins in Baltimore, because I just love treating the whole person. I wasn't particularly enamored by the heart or the lungs or the kidneys. I was like, I kind of like the whole person. So I became an internal medicine doctor. Then I worked as a hospital physician at a Baylor hospital in the suburbs of Dallas, a town called Plano. And I had moved to Dallas because I'd co-founded a company called Compass Professional Health Services, which was a healthcare navigation and price transparency company way back in 2007. That's right. We were giving price transparency for in-network allowed amount information for employees on Blue Cross, United, Cigna, Aetna way back in 2007. We grew that company to over 2,000 employer clients, 1.8 million people. And then in 2018, we sold that company to Alight Solutions, which was a subsidiary of Aon, which Aon had spun out. And now Alight is its own publicly traded company, but they've got 10,000 employees. And then I realized that there was still so much of lack of understanding of how kind of the healthcare system worked on the part of employers and broker and consultants. And I'm like, okay, I'll start making these videos on YouTube and LinkedIn. And that's where A Healthcare Z was born. And it has become much bigger than I ever would have imagined. I mean, literally, we have people from multiple countries that are viewing right now. We have over 120,000 views a month across these 300 videos that I've created. So I really appreciate all of you watching the videos. And then I've been asked to be the medical director for Simple Pay Health within the last several months, which is an alternative health plan as well. So it's great to be able to work with them too. So brief background about myself done. Let's move on to alignment. So today, the major challenge for employer-sponsored health plans, and really even for government payers like Medicare and Medicaid as well, is really misalignment. What do I mean by that? Specifically for employer-sponsored health plans. Listen, what do the employee health plans want? They want high quality. They want good stewardship of the money. In other words, don't be wasteful. I think everybody can understand the concept of not being wasteful. So don't be wasteful. And then at the end of the day, for self-funded employers and even for fully insured employers, it's really the employer that is bearing the risk. The risk-bearing entity is the employer. So about 65% of employees in America are on what are called self-insured plans. Okay, self-insured is when the employer is bearing the risk. Okay, so by definition, self-insurance is an oxymoron, right? Because the definition of insurance is the transfer of risk. And so if you're self-insured, you're essentially not transferring the risk. So it's not insurance at all. So self-insurance is, at the end of the day, the employee benefits in the health insurance world are filled with euphemisms, and self-insurance itself is a euphemism. Okay, so now what do insurance carriers want? Listen, the vast majority of them are publicly traded. They want more revenue, they want higher margins, and they want to bear as little risk as possible. In fact, the major health insurance companies don't even call themselves health insurance companies. They call themselves health services companies. You go to the quarterly reports, the annual reports for United and Cigna. They say that they are healthcare services companies. They don't say they're health insurance companies. In fact, Cigna, on one of their more recent quarterly earnings call, actually said, their CFO said, that the majority of their revenue, something like 55% or 60% of their revenue, is not risk-based. In other words, it's not based on insurance at all. So the majority of these health insurance revenues has nothing to do with risk. And they don't want to bear risk, right? That's like hot potato. They want to bear as little risk as possible. Okay, so then what do doctors and hospitals want? They want more patient volume. They want more stuff for more people, because in a fee-for-service payment environment, that's how it works. Now, anybody can say anything they want, but that's how the incentive structure works in a fee-for-service environment. And they don't want to bear any risk. And so when they contract with the insurance carriers, like, they don't want to bear any risk in those contracts. And in fact, those contracts actually allow the hospital system to make more money when they have more complications from surgery. In fact, there was a study published by Atul Gawande, famous doctor Atul Gawande from Harvard, in the Journal of the American Medical Association in 2013, where he looked at the data for a large hospital system here in Texas and found that that hospital system was paid more by commercial insurance the more complications they had for patients. Their surgical patients that had complications, the hospital made more money and actually had a higher profit margin on them. Well, shoot, if you're an employer, you would never want your insurance carrier negotiating a contract that allowed for that. Now, I don't think any surgeon is going out of their way to cause complications, but the point is that the hospital bears zero risk for that and actually financially benefits from it. So the employer is totally misaligned with the major players that provide healthcare services for their employees and their family members. The health insurance carrier is not aligned with them, and the doctors in the hospitals are not aligned with them. Okay, so what's the new model? The employee health plan wants to work with others. Employers want to work with others that actually want higher quality, that want financial stewardship, and frankly, that bear risk. Okay, so what's a way to do that? What's a new way to do that? The organizations that are bearing risk are also providing the care. What's that called? That's called capitation. This is not a new concept. Nobody calls it capitation anymore, right? It's all referred to as an ACO or an alternative payment model, blah, blah, blah. Like, it's capitation, okay? Now, one of the keys to this model of capitation 2.0 is you don't want the providers doing less to make more money, right? You don't want the doctor to be like, well, I can make more money if I just, let your cancer go, right? You would never want that to happen. So the key here, and oh, by the way, this is not a new concept. This has been done by hospital systems in America for over 100 years. The physicians at the Mayo Clinic are all on salary. The physicians at the Cleveland Clinic are on salary. The physicians at Johns Hopkins and the majority of academic medical centers in America are on salary. Whether they do or do not do surgery or place a stent in your coronary arteries does not impact their income. So their clinical judgment, it's not perfect, but their clinical judgment is as minimized as possible by the financial implications of their clinical judgment. They do not get paid more or less if they do or do not place a stent or take you to the operating room. And that, in my opinion, is the best way to have that set up. So when this is the punchline, this is the thesis for this entire presentation is right here, is right now, is the lens that everyone should look at healthcare innovation when they have an employer-sponsored health plan, has a vendor come talk to them, or even their carrier comes talk to them, or whatever. They need to look at that innovation of technology or software or services or health insurance products or whatever through the lens of alignment. Okay? It's not the fancy app. It's not the data. It's not the analytics. It is, how does this innovation create greater alignment than what I have today? And if it doesn't solve your alignment problem, then you should say next and move on to the next vendor. So that is the point, is we have to create alignment. So now we're going to talk about examples of alignment. So again, this is not some sort of crazy Eric Bricker idea. This is happening today. Now, it's happening in the form of near-site and on-site clinics. It's happening in the form of insurer-employed physicians by UHC. It's in the form of second opinion programs from Walmart. It's in the form of fraud, waste, and abuse audits by Quest Diagnostics. For the sake of time, we're going to skip over consumerism today. And it's also, all of this has to be communicated. So interestingly, one of the most important things that employers ask me about is communication strategies. So no discussion of alignment would be complete without a discussion of communication strategies. Okay, now I'm going to pause here for a minute. And well, good morning to all you folks. I see lots of good morning from Ghana. Thank you so much for being here from Ghana. From Ghana to New Jersey. I mean, you got it all here on A Healthcare Z. All right. So Sherry Free makes the excellent point that it's self-funded, not self-insured. I agree. That's a much better way to describe it instead of saying self-insured. All right. Excellent comments. Thank you so much for posting all those. Now, let's talk about on-site and near-site clinics. So this is where essentially the employer who's bearing the risk is providing the care. Now, there are some employers, like there's a big school system and municipality in the Dallas area that has their own clinic. Now, they employ a doctor. Now, or they're vendoring it out. And this is what Amazon has done with Crossover Health. It has its own employee health plan clinics. Where did it roll it out over 2 years ago? First place in America, here in Dallas-Fort Worth. Why? Because Dallas-Fort Worth has some of the highest commercial healthcare costs in America. So the doctors and hospitals in Dallas have higher per unit costs and do more units than other large cities like New York and Chicago and Houston and Miami and Atlanta and Los Angeles. So the people at Amazon are no dummies. They make data-driven decisions, and they looked at their data for their employee health plan and said, if we're going to put in a near-site clinic anywhere, we're going to do it in DFW. And so Crossover Health is, by the way, high-end near-site company. I don't have any association with them. They do the near-sites for other technology companies like Microsoft and Apple, and they do primary care and musculoskeletal and behavioral health and coaching. They do it near-site. They do it telemedicine as well. Look at those hours, 7 a.m. to 11 p.m., Monday through Saturday. What does that tell you? Access. Access is like A number one, right? If you can't get people to access the primary care, then it's not going to work, right? Your local hospital system doesn't give you that type of access to primary care. Like, this is A number one. And then number two, what do? It is zero out-of-pocket cost to the employee. So again, Amazon's no dummies. You give it to them in their homes with virtual. You give it to them at extended hours at night and on the weekends, and you make it at zero out-of-pocket cost. Now, that then begins the question, okay, well, Amazon's big purchase in healthcare that they just made was for One Medical. One Medical is essentially a much larger version of Crossover Health. Crossover Health was kind of niche for these very high-end technology companies. They didn't have a bunch of clinics. One Medical already had scale. And so I don't know Amazon's exact calculus in going in this direction, but they're probably like, look, this crossover health thing, like it's the future. Crossover health is kind of too small. But One Medical is very similar to crossover health and is much bigger, and it allows us to scale it. So Amazon's One Medical acquisition is essentially an opportunity for them to scale what they're doing right now with crossover health. Now, this whole primary care approach has already been proven to work. If you want to increase quality and lower healthcare costs, primary care has already been proven to work. Okay. And Dr. Brent James, who is the head of quality at the Intermountain Healthcare System in Utah, define third generation medical. Now, not all primary care works. It has to be third generation patient centered medical home where you've got disease management, mental health, and health system navigation all combined in a non fee for service setting. So these crossover health doctors aren't trying to churn through 30 patients an hour to get paid fee for service, right? Because they're essentially been hired by the employer. There's no claims. You can have care without claims. Likewise, for the primary care in these third generation medical homes for Intermountain Healthcare, there's zero claims. Why? Intermountain runs their own health insurance company. You can buy Intermountain. It's not called Intermountain Health Insurance. It's branded a different name, but you can buy that it's vertically integrated. They sell the insurance and they provide the care. Guess what they found? So they are financially in line with their plan participants and the employers to improve quality, to decrease cost, to increase access. And guess what happens when you're financially aligned with your customers? Hospitalizations down 22%. Let's say you went to a hospital system and you said to the CFO and the CEO, hey, we've got this fantastic innovation that's going to decrease hospitalizations by 22%. Guess what they would do? They would hide that solution as quick as humanly possible. Hospital CEOs and CFOs do not want to decrease hospitalizations by 22%. That would scuttle their entire hospital system. So just know that in a fee-for-service environment, like hospital systems do not want third generation patient-centered medical homes. They do not want that. That is like the last thing that they want. Okay. ER visits down 11%, imaging down 11%. Here's the key here. It doesn't affect the per unit cost. It affects the number of units, right? Healthcare costs are very simple equations. It's the unit cost times the number of units. So primary care is your high cost claimant strategy. Okay. It's not complex, inpatient management. Listen, once the person has liver failure in the hospital, there is nothing you're going to do to fix that. Like they're in the hands of the hepatologist in the hospital. You as an employer or an insurance carrier, you're going to do nothing for that person. But primary care delivered by you is the way you're going to do that. Who does this? Municipalities and school systems in Wisconsin. Who does this? Municipalities and school systems in Indiana. Why? Wisconsin and Indiana also have two of the highest commercially insured healthcare costs in America. So you get the point. I'm moving on. Okay. Next up, we got to talk about CVS Aetna's health hubs, right? Everyone is familiar with these health hubs. It's been in the news for quite a while now, and they've created gobs of them here in the DFW area where they took these minute clinics that were within the CVSs and they've expanded them to not only do acute illnesses, but also do chronic conditions. They've got them in DFW, Boston, Maryland, North Carolina, Ohio, and Virginia is where they started out. They've got 40 of these in DFW. So obviously they have a lot more than 40 CVSs in DFW, but they've got 40 locations here. Now, these CVS health hubs, if you were to contract with CVS Aetna, then that would be fine. You would essentially be using CVS Aetna akin to Crossover Health. They would be your near site clinic company, but they would be your near site clinic company at these 40 locations across DFW or Boston or, Maryland or wherever your employees were located. But there's a problem. So CVS Aetna has a conflict of interest. And that conflict of interest is that because they own this huge PBM. And so if you're a shareholder of CVS, if you're listening to those earnings calls, you're like, oh, well, this is a fantastic opportunity for CVS Health Hub practitioners, prescribers, to prescribe more medication so they can increase the script count on the PBM, right? One of the key metrics for PBM performance is script count. So maybe you could treat diseases with medications that probably didn't need to, like viral upper respiratory tract infections, right? If you go to, the standard of care for a viral upper respiratory tract infection for an adult is no antibiotics. Okay, that is the standard of care. It is subpar care to give antibiotics for a bronchitis. Okay, so but if you are a shareholder of CVS Aetna, you want the CVS Health Hubs to prescribe as many medications as possible, even for conditions that might be better treated without medications. And then two, you want them to specifically prescribe medications that have the best rebates to maximize the rebate payments and spread pricing to the PBM. So if you're in a tight spot if you're CVS, because if you don't do that, your shareholders are going to be like, why aren't you doing that? You have a fiduciary responsibility to us as shareholders to do that. So, but of course, if you're an employee, you're like, well, look, I don't want you making more money if you prescribe me a medication for a situation where you shouldn't be prescribing me a medication. So there is a conflict of interest there. Okay, so that's the CVS Aetna issue. Now, I'm just looking here at your questions and your comments. Thank you so much for putting them. All right. Love the comments. Thank you for them. I haven't really seen any questions in here to answer, but I appreciate the comments that you're leaving. Okay. Next up, we're moving on to the United Healthcare Harmony Network. You might be familiar with this. So, they call it Optum. We're just going to call this United because I think the whole idea of calling it multiple companies, I think that's the wrong way to think about it. It's United. It's one company, United Health Group. Okay. So United Health Group employs 6,500 doctors in Southern California. They have bought practices that are primary care practices. They've also bought multi-specialty practices as well. They have brought that to market in Southern California, Los Angeles area, Orange County, through an HMO product. Now, this is interesting because they chose, of all the places in America where they could have started employing their own physicians, they chose Southern California. Why? Because of two things. One, because if they, as a health insurance company, were going to sell an HMO product to employers and fully insured employers, and they were going to take on the risk, then they knew they had to have control. And the HMO product allows them the greatest control. Now, you go to Medicare Advantage plans. What are the Medicare Advantage plans? There are HMOs and some, but not as much, narrow network PPOs. The insurance company, if it's going to take on risk, they have to have control. Okay, what market in America actually has an appetite for HMOs? Southern California. So Kaiser is in California and Washington State and Washington, D.C., but Kaiser is actually bigger in Southern California than it is in Northern California. So like the biggest appetite where actually people are kind of used to HMOs and yada, yada, yada is Southern California. So that's why they got started there. Now, the number of members that they have there is super small. It's only 35,000 members. At the end of the day, that is a drop in the bucket. That's hardly any people at all. Okay, now, they're coming in with competitive pricing because if you can actually have the multiple, it's essentially the Kaiser model, right? So they are moving into the Kaiser model, but they're not stopping there. The next market that they are moving into is Texas, and they're also moving into Boston. Again, why are they moving into Texas and Boston, and specifically in Houston? So one, in Boston, because they have HMOs in Boston. Again, that's somewhat of a familiar, like if you were to put an HMO in Kentucky, you'd be like, what in the world is this? Right? Because they're not used to HMOs in Kentucky, right? So they're like, hey, we're going to places that already are kind of used to HMOs, like Boston and also Houston, because they bought the Kelsey-Seybold physician group. And Kelsey-Seybold is a 500, they bought it for $2 billion. It is a 500 physician practice, multi-specialty, that has 30 locations around the Houston metro area. It has 2 ASCs, and they already sell a Kelsey-Seybold HMO in the area. And so, again, why did they choose Houston? Because there was already an HMO, some degree of HMO familiarity in the marketplace, and Houston also has very high healthcare costs. If UHC can go in with an HMO product that has a 20% premium differential vis-a-vis the other fully insured products in Houston, that's huge. I guarantee you, who Houston employers will be very used to this. So what's the point in terms of alignment? You have the folks that are taking on the risk, providing the care. The folks that are taking on the risk are providing the care. That is alignment. Next up, let me go through some of your questions and comments again. Okay, all right, I'm catching up. You've put lots of comments in. This is wonderful. Okay, wonderful. Thank you here from William. Thank you for this question. Can AI be used to temper the desire for higher payments while guiding providers to better solutions? Okay, AI is a great topic. I will pause briefly for this issue. So, can AI help with what the term that's used is in healthcare or medicine? It's called decision support. Can AI help with decision support? And that decision support, really, it's hardwired into the EMR? The answer is absolutely. Now, one of the biggest issues is behavior change by the doctor. So just because it comes from quote unquote AI doesn't mean the doctor is going to do it, because you have to understand that no doctor is going to put their license and the ability for them to be sued by the patients on the line of some computer. So the key to AI in healthcare is a concept that is referred to as explainability. And all the healthcare AI companies that know what they're doing understand this. And so they've put great effort into the explainability of their AI to the physicians or to the prescribers or whatever who are actually needing to change their behavior, change from what they do today, what they think is best, vis-a-vis what the AI finds to be different and better. And so anytime you're evaluating any type of AI solution, like, that's what you need to ask about, is talk to me about explainability. And unless they can give you, evidence and experience around the explainability of their AI, then just the algorithms itself, like, isn't gonna give you the end result, right? You got to judge a tree by its fruit. So you're not going to have the type of fruit that you want unless you address the issue of explainability. But thank you for your question. Okay, I'm going to move on to the next topic. The Walmart Centers of Excellence. Of course, this is a program that many of you are already familiar with, also referred to as their second opinion program. Walmart's health plan spends $5 billion a year across 1 million members in the United States alone. Okay, $5 billion in spend is almost the revenue of a Fortune 500 company. So, like, Walmart's employee health plan in and of itself is like its own Fortune 500 company. Okay, so they've got a lot of smart people. Why do you think Walmart Health is doing so much in the world of healthcare? To a certain extent, they're trying to do it for their own health plan. Believe me, they've worked with all the consultants and all the carriers and blah, blah, blah. And they need to realize that they need to own it, that they are done trying to outsource the intellectual capital of fixing their health plan, they've got to do it themselves because it's an own Fortune 500 company's worth of now they do it for other strategic reasons too. So one, they're the low-cost provider of goods. And in order to be the low-cost provider of goods, they have to be the low-cost purchaser. Well, historically, they have not been the low-cost purchaser of healthcare services for their employees. So they need to become the low-cost healthcare purchaser for their employees in order so they can continue to pass on low cost for products in their stores. I mean, it's part of their ethos. I mean, that is their MO, their modus operandi at Walmart. And then number three is, interestingly, they need to solve healthcare for their customers because they found that healthcare was eating up more and more of the out-of-pocket costs for their customers so that they couldn't spend their money at Walmart. So they were essentially losing wallet share of their customers because healthcare was grabbing more and more, so that instead of buying like sandals or diapers at Walmart, these people were having to spend more money on their healthcare. And they're like, well, we can't have that. They need to buy more stuff at Walmart. So we need to solve this healthcare problem for them. Okay. So for their own employees, they create these centers of excellence, right? So fine. What is the key about, again, we're going to look at innovation through alignment. What is the alignment of these centers of excellence? It's two things. One, it is a warranty bundle, total knees, total hips, bariatric surgery. There is one price for the pre-op, the op, and the post-op, and it is warrantied. So in other words, it is specifically addresses that JAMA study by Atul Gawande, which is the problem with insurance carrier contracts. Today, insurance carrier contracts have no warranty. And so Walmart's like, we don't like that deal. We are going to directly contract with hospital systems that will give us a warranty. What does a warranty mean? That means the hospital system takes on risk. Aha, there it is. When we talked about in the early slides about other entities taking on risk, insurance carrier doesn't want to take on risk. Hospital systems don't want to take on risk. In order to get Walmart's Center of Excellence designation, you have to warranty your service and you have to take on risk. That is an alignment innovation. What's number two that they got to have? The doctors have to be on salary. You cannot be a part of the Walmart Centers of Excellence program unless your doctors are on salary. Why is that? Because when they're making a second opinion about you, they don't want the doctor making more or less whether they decide you do or do not need spine surgery, or do you do or do not need your knee replaced. They want that to be clinically decided, not based upon the doctor making any more or less money, biasing their decision. So it's a requirement. What happens? What do they find? What are the outcomes? Spine surgery, second opinion, 50% of the people don't need surgery. Readmissions down 95%. Joint replacement, 20% don't need the surgery. Readmissions down 70%. Bariatric surgery. Listen, for some people, the data has shown that bariatric surgery is actually life-saving. I mean, they essentially were going to die from their morbid obesity. 70% decrease in drug costs. I mean, you can literally reverse their out-of-control type 2 diabetes. You can cure them of their, not all people, not all diabetics, not all obese people, but for a select population that fit the proper requirements that the Bariatric Surgery Center of Excellence has, you can cure their type 2 diabetes. They no longer have diabetes. They have a Center of Excellence program at Mayo where over half the time, the treatment plan changes. So just know that if you got employees that are going to community hospitals for their oncology care, if you yourselves were to use a Center of Excellence program that sent people to Mayo, that Mayo would change the clinical plan that you're paying for over half the time. They change the diagnosis 10% of the time. A lot of the times the cancer, they could think it was one type of cancer, it's actually a different type of cancer, which you have to treat differently. Or two, severe inflammation or autoimmune diseases can sometimes look like cancer underneath a microscope, but when they had the pathologist at Mayo review it, they're like, oh, this isn't cancer at all. You shouldn't treat this with chemo because it's not cancer. It's severe inflammation from a really bad infection, or it is an autoimmune disease causing really bad inflammation that looks like cancer. Okay. Next up, fraud, waste, and abuse audits. Okay. So again, lack of alignment. So if you're an employer, if you're an employee at your company, you want to make sure there's no fraud, waste, and abuse in your plan at all. Okay. Now, if you're a health insurance carrier, they all have fraud, waste, and abuse departments. But if you're the ASO for a self-funded plan, you're taking on no risk. You're taking on no risk for that FWA. So, like, how thoroughly are you going to do that FWA when you're not at risk for it? Like, do carriers do the exact same FWA process for their self-funded plans that they do for their Medicare Advantage plans? I don't know. You'd have to ask them. So, Quest Diagnostics, self-funded employer, specifically went out and targeted, among other things, fraud, waste, and abuse on their plan. Who did this? Steve Goldberg. I know Steve Goldberg. He's a great guy. He is a primary care physician. He was a medical director at Humana, and then at a Medicare Advantage plan, was brought in to Quest to run the employee health plan. He had ultimate responsibility for the employee health plan. And so one of the things he said is that, look, I know the billing is a disaster, and I know that our carrier is not catching all the disasters, and they're paying the claims on it. They're paying claims on stuff that's total fraud, waste, and abuse. And so they, because they were a large employer, they got the detailed claims data and they reviewed it themselves. And they would alert the carrier to fraud, waste, and abuse. And that was super important, because what happens is of course, the carrier's already made payment on it the vast majority of the time. But what can the carrier do? They can withhold future payments to that specific hospital system, because the Quest employees will still have employees going to this particular hospital system, and they can withhold future payments to that hospital that are equal to in worth to the fraud, waste, and abuse that was caught. And there was a specific example of that he told me about. It was a $95,000 outpatient ankle surgery at a hospital. And he was like, whoa. There is no way that an outpatient ankle surgery should cost $95,000. He and his team at Quest caught that. The carrier had already paid the claim. The carrier's FWA process didn't carry it at all. And it happened over and over and over again. So what did Steve Goldberg and his colleagues do? They had to keep their carrier and their broker consultants on a short leash. What did they do? They met with them every 2 weeks. And they said, look, here are some more claims. Meet 2 weeks later. Here are some more claims. Met 2 weeks later. Here are some more claims. What did they do every 2 weeks? What happened to the claims I gave you 2 weeks ago? 2 weeks later. What happened to the claims we gave you 2 weeks ago? To hold them accountable. Meeting with the carrier every 2 weeks is not something that most employers in America do. That's what Steve did. Their results. Punchline. Went from a trend of plus 5.7% to a trend of negative 1% over 3 years. Now, they did other things as well, but the FWA was a key piece of this. And how do I know this? Because Steve Goldberg published this in an academic journal. Can you think about the amount of time it took him to publish this in a journal? But he took the time to publish this so that anybody can read about what he did and emulate it themselves. Again, because he had vendors, carrier, broker, consultant, who were not financially aligned to his plan. So he had to do it himself with his team. Sorry about that. Next up. Okay. Communication strategies. Now, all of this, whether it be, informing folks about the on-site near-site clinic, whether it be, working with employees around a second opinion program, There are behavior changes that are required for implementing a lot of these alignment strategies with a employer-sponsored plan. And that requires communication. And so here is a piece about communication. And we're not going to talk about emails. We're not going to talk about text messages. We're not going to talk about, mirror clings. We're not going to talk about, all of these, routes of communication. Because at the end of the day, word of mouth is an important form of communication within any organization. The employees talking to each other about their health plan and their experience with the health plan. And here is the key, is that your health plan or the program itself must be remarkable. And the word remarkable means literally worthy of remarking about, worthy of talking about. So that is the key. Unless the offer to the employees on the health plan is worthy of remarking about, then no amount of text messages, emails, in-person meetings, blah, 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 they won't work. The offer itself to the employees and the benefit to them has to be remarkable. In other words, the marketing for the program has to be built into the product itself. This is not an Eric Bricker idea. This is a Seth Godin idea. Okay, Seth Godin, one of the world's greatest marketers, says you cannot market effectively. What's marketing? It's communication. You cannot communicate effectively to a population unless the offer itself is worthy of people talking about. What are some remarkable offers that people can give? 0 out-of-pocket cost. Employees understand free. Going to the Onsite near-site clinic, going to the second opinion program for themselves and a family member, 0 free. Okay. Oftentimes, in order to do that, it requires a direct relationship with a vendor outside of the carrier. It's care without claims. Care without claims. So anytime you're thinking about innovation for your plan, think about yourself. What's a way I could provide care without claims? Because inevitably, that is going to create an opportunity for you to create a 0 out-of-pocket cost relationship for your employees. Okay. Next best after free, copays. Okay. What is a copay? It's just a price in advance. What do people understand when they buy things? They understand a price in advance. So they understand a price difference in advance. Deductible and coinsurance, you don't know. You don't know what anything costs in advance. It's some sort of hocus pocus. Even if they tell you the price in advance, it might not be the price afterwards because the doc or the hospital screws it up, right? Something between 30 and 50% of medical bills have errors on them. They'll screw it up. But if you give a copay, that is a known price in advance that people can then use as part of their decision making. So you've got free, and then if you have to charge for something, you give them a copay, okay? Now, this requires, last bullet here, this requires adjudication customization. This requires either taking things out of the claims relationship completely or having a client-specific network or a customer-specific network, a CSN, which typically a major ASO cannot do. It requires a TPA to do that. And so really, interestingly, I have talked to very large employers who use TPAs, and I was shocked. I was like, you got to be kidding me. You have this many employees, tens of thousands of employees, and you use a TPA? That's right. Because they knew that they needed to create alignment innovation within their employee health plan, and they knew their carrier ASO could not do that. So just know you got to take stuff out of the claims process completely, or you have to have tremendous customization in the claims processing through client specific networks in order to make it possible. Now, next up, take home points. 1, align incentive. Change who is providing the care. So people can say, okay, well, we want to change the payment system. We want to change the payment system. Look, and that's fine, but don't try to boil the ocean. Don't try to change the payment system for everyone. Okay. Niche a narrow group of providers and change the way you're paying them. Okay. Guess what that is? That's called an on-site near-site clinic with primary care. That's the key there. Okay. 2, you've got to take matters into your own hands. Okay. To avoid conflicts of interest. Listen, Elizabeth, I'm blanking on her last name. I apologize so much to you, Elizabeth. She's the CEO of the Purchasers Business Group on Health. It used to be the Pacific Business Group on Health. She has come out, and there's a video on LinkedIn where she said the health insurance industry and the healthcare industry has been completely unresponsive to employers and employees in America. And so it's time for employers and employees in America to own this problem, to take it on themselves. Because for decades, they have tried to have health insurance carriers and the healthcare industry help them solve this problem. And she said that the industry has been unwilling to change. She didn't say incapable. She said unwilling to change. And so guess what the Purchasers Business Group on Health is doing? They're creating their own PBM. They essentially have said, look, our PBMs are tone deaf. They refuse to give us what we're asking for. So, and then they look around. They're like, well, where's the competition? Where are the other PBMs that we can go to? They look around. There's no competition. They have to create their own. That almost by definition means there's not enough competition in the marketplace when the customers have to create their own company to service them. Okay? So, now, in order for costs to be lower, plan members need to be more cost conscious. Now, again, use it if you want, and this is really my point with consumerism. If you want people to be cost conscious, then you have to do that through a copay mechanism, because that's the only way you can ensure, that's the only way you can guarantee price certainty to a patient, to an employee, to a plan member, is through a copay. So just know that through zero out-of-pocket costs and through copays only, there are ways to create price certainty, to create alignment with your employees themselves. Again, this isn't just alignment with the health plan. This is also the alignment with the patients, with the employees, with the plan members that are on the plan itself. This is totally doable. And I've told you about Quest Diagnostics. I told you about Serigraph. I told you about Walmart. Serigraph only has 1,000 employees. They're self-funded, but they're not huge. Like, you can do this. This is totally doable. And with that, I want to thank you all for being here today. I just want to say, look, if you want to connect with me on LinkedIn, I would love for you to do that, because then you will have my videos show up on your LinkedIn feeds if you think my content is, worthy of being viewable, if you think it's remarkable. And that's the easiest way to get the content. Now, if you also want to email me to subscribe to my A Healthcare Z newsletter, I'd be happy to put you on my video newsletter that goes out Monday through Friday. But either LinkedIn or email me to get on the newsletter would be great. Now, you've asked some great questions here. And make some comments. So we have some time here at the end. So please continue to ask more questions and leave more comments. And I'm going to go through and answer some of these now as well. Okay, great. Thank you. Wow, this is fantastic. William says, since bariatric, I assume he means surgery, down 125. I assume he means pounds. That is amazing. 5K runner, and I'm 6 years post-op. The right programs work. I mean, shoot, Al Roker, right? I mean, William, this is fantastic. Congratulations to you. I mean, this is life-changing, life-saving for people. Not all people. Not all people are the right candidates for bariatric surgery. But if you can find the right person, then the results are amazing. Okay, more questions and comments. Thank you so much. Is it an accurate statement to say that Medicare Advantage is a better example of alignment in incentives? Great question, Terry. Thank you for asking that. So Medicare Advantage plans do have the minimum loss ratio requirement that's sort of analogous to the fully insured plans from Obamacare. So they need to have an 85% loss ratio. So in other words, they can only keep 15% there. So they are capitated. And so they are financially aligned to provide as much high quality, cost effective care as possible. Now, here is how Medicare Advantage, though, is being abused. And there was a New York Times article about this recently. And that is that those capitated payments are risk adjusted for the severity of the illnesses of the patients on the Medicare Advantage plan. And so, having diabetes and hypertension, having very uncontrolled diabetes, having very uncontrolled hypertension, that means you're a higher risk patient, which means then you send that score over to the government, and the government gives you a larger check per month for a 65-year-old with hypertension and diabetes than for a 65-year-old who has no medical problems. I mean, there's plenty of healthy 65-year-olds out there that have no medical problems. And so the issue that the Medicare Advantage companies either have gotten in trouble for, or they've settled and admitted no wrongdoing, is for inaccurately skewing those risk adjustment scores and essentially overstating that the diseases that the people had in order to maximize the reimbursement. Listen, now one person's overstating is another person's maximizing, right? So the eye is in the beholder, but that has been an area that has been problematic for Medicare Advantage plans. Okay, but in terms of actually the people who are providing the care, and this is the ChenMed model, and the people of providing the care taking on the risk. The reason why that's so important is because, listen, docs and hospitals, they know how to take better care of patients. They know how to do it. They just need to be incentivized to do it, right? Intermountain is incentivized to do it because they're at risk. ChenMed is incentivized to do it because they're at risk. Guess what Medicare Advantage plans provide? Guess what ChenMed provides? Food. They give their patients healthy groceries because they know that food insecurity and unhealthy eating is a horrible risk factor for disease and hospitalization. And one of the best ways that a primary care physician can help a patient stay out of the hospital and stay healthy and have a wonderful life is to get them to eat better, in part by counseling and also in part by providing them with better food. This is not rocket science. What other fee-for-service hospitals in America give their patients groceries? Okay. Do you see any alignment? So Henry is asking a question here. Do you see any alignment with large dialysis companies? I have made several videos about dialysis, and dialysis as it exists today. In the vast majority of dialysis patients are fee-for-service. So you can put fee-for-service dialysis in the same category of misalignment that you can put all other situations. Now, could you have risk-based dialysis? Of course you could. Would the providers change what they do when they have risk-based dialysis? Of course they would. Would they do more home-based dialysis? Would they do more peritoneal dialysis instead of hemodialysis? Probably. So there's tremendous, again, the answers are out there. The innovation is alignment innovation. Okay? That's the innovation. All right. Great questions. Thank you so much. So I'm going to stop there. Okay. Listen, you folks have been absolutely fantastic. I hope you have a fantastic rest of your Monday. I'm a man on the go. That's why I'm in my car. So thank you for being patient for me here. And I'm like blocking out the sun with a cardboard box. I mean, you folks are so kind for putting up with me and my ridiculous videos. So anyway, have a great rest of your day. Thank you so much for watching. Take care. We'll see you next Friday at 8 a.m. Central. Bye now.